So good morning, everybody, and welcome back to Journal Club. Today's topic of discussion is looking at mitral clip, or specifically edge-to-edge mitral valve repair. I'm particularly looking at failure, mechanisms, and outcomes. It's a great pleasure to welcome friends back to our Journal Club. So Claudio Montalto from Milano, thank you for joining as presenter and as expert and author of this paper and many papers in this field of mitral, a real expert, Antonio Mangieri from Humanitas Hospital in Milano. Thank you both of you for joining us. Claudio, if I can invite you to share your screen and we can then get started.
Can you see my slides now?
Working perfectly, yeah.
Thanks, Harry, for the introduction. Thank you for the invitation. It's a great honor to be here today and to speak about this paper that was recently published in JACC Cardiovascular Intervention, and to have Antonio with us today, who is the lead author of the paper and one of my mentor from San Raffaele. So why it is important to speak about transcatheter mitral valve repair and what happens when it fails? Because mitral regurgitation is the second most common valvular heart disease in Western countries. And when it comes to guideline indication to transcatheter edge-to-edge repair, these are the guidelines from the most recent document from the European Society of Cardiology published in 2021. We see that with primary etiology, which is the most common one, TEER is indicated for symptomatic inoperable high-risk patients, while surgery is the really gold standard in these cases. These indications are actually mutuated by the results of the Everest 2 trial that showed superiority of surgery in terms of freedom from death, MV surgery or operation, but this endpoint was mainly driven by freedom from mitral valve surgery or operation, with similar rates of death at 5 years follow-up, basically, between mitral clip and surgery. When it comes to secondary mitral regurgitation, well, in this case, of course, there are some indications from surgery, but TEER should be considered for symptomatic non-operable patients fulfilling the COAPT criteria. The guidelines clearly suggest to use the COAPT criteria to screen for patients that might benefit from TEER, and this is because of the results of the famous COAPT trial, which showed superiority of mitral clip on top of optimized medical therapy for patients with heart failure. And these results, on the other hand, were not matched by the other important randomized trial in this area, that is the MITRA-FR trial, that showed no difference in terms of mortality between the patients treated with optimized medical therapy or mitral clip on top of optimized medical therapy. This is basically why how literature recognized that this trial were very different, probably because they enroll different patients. In particular, it is now acknowledged that only patients that have a mitral regurgitation that is actually disproportionate, so more severe than one would expect with regards to the LV dilation and dysfunction, that were the patients that were actually enrolled in the COAPT trial, those patients will benefit from TEER, while patients with less severe MR with respect to the degree of dilation and dysfunction will probably not benefit from TEER. So the guidelines clearly suggest to enroll these patients and to treat them with mitral clip on top of optimized medical therapy, and they clearly cite the COAPT criteria in the document. Also, TEER may be considered in selected high-risk symptomatic patients that are not eligible for surgery and not fulfilling the criteria. In this image, we can see the evidence behind the recommendation of the European Society of Cardiology. So we have two, in degenerative and functional MR, we have randomized clinical trial to support the indication, but also for other etiology or complex anatomies, such as hypertrophic obstructive cardiomyopathy or patients undergoing surgery for heart transplant or LVAD. We have case series and registries that actually support the use in selected patients. So it's clear that the landscape of patients that might be treated with transcatheter edge-to-edge repair is expanding, and this is why it is important to know what happens when TEER fails. And this is the paper that was recently published on JACC cardiovascular intervention. It is a paper about an international registry that enrolled, the film registry that enrolled over 4,000 patients treated with a mitral clip in 19 centers between 2009 and 2020. Of these 4,294 patients, 147 or 3.5% underwent mitral clip failure. The events were adjudicated according to the MVAR criteria, and the mean follow-up was 163 days. In our registry, that is the biggest, the largest available in the literature, we also clearly defined if patients had a loss of leaflet insertion, a single leaflet detachment, or a clip embolization as a mechanism for failure. So single leaflet detachment is when there is a complete loss of attachment of the mitral clip or other device to one of the two leaflets on the mitral valve. Loss of leaflet insertion is when the mitral clip is still attached to both leaflets, but there is a tear or another kind of dislodgement that actually cause significant MR to occur. And finally, there is, of course, clip embolization when the clip fails to attach to both leaflets, and then it, of course, the device embolizes. Of the 147 patients that we enrolled, 67 had a functional etiology and 64 had a degenerative etiology, and finally 16 had a mixed etiology. When we observed the rate of failure in our registry, which was 3.5%, this is very similar to what is observed in the Everest 2 trial, 3.2%, while it is very different and higher than what was reported in the CRAPS trial that reported a failure of less than 1%. So this actually is very interesting. It tells us a lot about patient selection and the appropriate patient selection to that might also minimize the rate of failure in this of mitral clip failure in these patients. This is the only other large registry on mitral clip failure available in the literature. It was published in 2021, and it is a single center registry that enrolled 96 patients with mitral clip failure, and they reported in their case series a very high rate of mitral clip failure of over 11% of patients. Again, of course, this is a single center registry, so it is expected that some heterogeneity might actually be present with compared to our multi-center registry. Our patients were predominantly male. They had a mean age of 77 years and a mean STS score of 3.8. Again, when we look at functional etiology, we see that CRTD was present only in 30%, almost 30% of our patients, which actually accounts again for optimized medical therapy in these patients that might probably be further optimized before TEER implantation. And of course, end-diastolic volume was very large and significantly larger in patients with functional etiology. This was a registry that included only mitral clip model and all the models, so both the very early iteration of the device and the more recent NTR and XTR group. Final mitral valve gradient was actually very good. And when we look at the culprit for the device failure, we see that the posterior leaflet is most common involved in 80% of the cases for loss of leaflet insertion, and in 70% of the cases for partial clip detachment. And clip embolization was very rare in our cohort, with only one case reported. When we observe time of diagnosis, we see that 32% of our patients were diagnosed intraprocedurally and another 28% intra-hospitally, for a total of about 60% of patients that were diagnosed before hospital discharge with mitral clip failure, and another 40% that were diagnosed later at follow-up. Median time to diagnosis in this case was 6 days from the procedure. In this graph, we can see the report of the mitral clip failure diagnosis from day to day in the graph on the left, and month to month on the graph on the right. And again, we can see that it is often a very early onset event, but it can occur also very late at follow-up. When we, in our registry, the most common treatment for these patients was medical therapy that was used in almost 50% of cases, while redo MitraClip was the strategy preferred in 35% of the patients, and surgery in 17% of the patients. And when we dive into these results, we see that of the 89 intra-hospital failures, 38% needed either inotropical or mechanical circulatory support, and 48% underwent a redo procedure, including 14 redo MitraClip and 15 surgery. Of these 15 surgery, 4 were procedural conversion to surgery. So it's clear that this is both an early event, often, and also a clinically significant and potentially life-threatening event. Of the 58 failures that we observed that follow-up, 50% underwent redo MitraClip, 14% underwent cardiac surgery, and 36% were managed with medical therapy alone. At follow-up, we observed 29% of deaths, and 12 of these 43 deaths were in-hospital deaths. We also observed 4 major or life-threatening bleedings, 35 post-procedural ACI, 17 other serious in-hospital complications, including sex LVAD required. And at follow-up, 50% of 50 patients, which accounts for 44% of our patients, had moderate to severe MR. When we observe the Kaplan-Meier, so the survival curves, we see that redo MitraClip in yellow is actually associated with a numerical reduction of deaths at follow-up, but this reduction is not statistically significant. On the other hand, this is the original Kaplan-Meier curve that we wanted to show in the paper, while the other one was required from the reviewers. And we see that when we combine surgical and conservative approach in only one arm, we see that a strategy of redo MitraClip is actually significantly better than surgical or conservative approach together, so non-redo MitraClip strategies. And this actually probably suggests us that we didn't observe a significant difference in the three-way Kaplan-Meier because of a problem of numbers and underpowerment of our studies, but probably there is a significant association with redo MitraClip and less deaths at follow-up. These are the results of the other registry we already mentioned. Again, the results are very different from our registry, with surgery for primary mitral regurgitation being the best treatment at follow-up, but also surgery being the worst treatment for secondary mitral regurgitation, while redo MitraClip had very similar results for both secondary and primary mitral regurgitation in this registry. And finally, we also did a multivariable model for that at follow-up, and redo MitraClip was again associated with a significant reduction and an independently and significant reduction of death at follow-up, with also age, moderate to severe TR, and post-procedural ACI being significantly and independently associated with death, increased death in this case at follow-up. We also reported the occurrence of death according to loss of leaflet insertion and single leaflet detachment alone, and we see that there is a trend toward increase of death in patients that had a loss of leaflet insertion versus single leaflet detachment. And when we observe the strategy used to treat these patients, we see that again there is a numerically lower deaths in patients treated with redo MitraClip, both if they had loss of leaflet insertion and if they had single leaflet detachment. These are the results in terms of mitral regurgitation at follow-up, and we see that at follow-up, basically moderate or severe MR is present in almost 50% of our patients, and but without any impact on LVAF deterioration. In conclusion, this might be the take-home messages from our studies, that in high-volume centers, MitraClip failure is relatively uncommon, 3.5% in our real-world registry, but it is associated with high rates of moderate to severe MR, about 44%, and death about 30% at follow-up. So this is a clinically significant event. It is often an early event with an intra-hospital diagnosis of 60.6%, and it commonly involves the posterior leaflet. So suspicion should be very high in the first hours after the procedure and the first days after the procedure before discharge, but it also can happen afterwards and later at follow-up. An upfront redo MitraClip strategy was associated with a trend toward a reduced rate of death at follow-up versus surgical or conservative management. And finally, also age, acute kidney injury, and concomitant moderate to severe TR were found to be independent predictors of mortality. Again, thank you all for the attention. For those who want to read more, our paper is available on cardiovascular intervention, and I'm very happy and honored to give word now to Antonio.
Great, thanks, Claudio. That's an excellent summary, and many congratulations for this work and this paper. Antonio, can I ask you to come in, please, and give us your perspective, both on this paper, but also generally this field and this topic?
Okay, thank you, Arif, and thank you to Claudio, because it's quite difficult to summarize all the paper, because we tried to do so many analyses, because as showed by Claudio, there are not so many papers regarding this concept, and especially this phenomena of mitral clip failure. So I think this is an important phenomenon, and of course, maybe Claudia has not talked about the limitations of this paper, because there was a retrospective collection of data coming from different centers, and maybe we missed something, especially the follow-up, because the follow-up was not performed in all the patients in a methodological way. Another important aspect that I want to also to underline is that with the passing of time, we have changed something, especially in the diagnosis, because nowadays it's very easy to do very sophisticated and specific diagnosis of mitral clip failure, especially of the single leaflet detachment and loss of leaflet attachment. But in the past, especially with the only 2D echography, was very difficult, especially to see and to identify the mechanism of mitral clip failure. So I think that in the recent years, we have more power to diagnose this phenomenon. As you have seen, the aspect is quite dramatic, because almost all the patients, half of the patient hands at 1 year with residual moderate to severe MR. I have to say that I don't know exactly what's going on with the new models, because almost our registry is based on past experience with the first and second generation mitral clip, which was smaller, with a smaller and not so wide arms, which allows not a meticulous and precise leaflet grasping. Nowadays, we have power tools, new mitral clip with the G4 generation, which allows independent leaflet grasping. The arms are wider. There is with the 3D echo, more precise capacity to grasp in a specific way. And the resolution of 3D machines is so high that actually maybe the rate of failure related to single leaflet detachment or loss of leaflets insertion maybe is lower, but I don't know. We tried to find, to identify a trend towards the years, but I have to say that in the recent years we have found not so much reduction in the rate of mitral clip failure. I have to say that an important aspect that is not underlined is that actually people are looking for this dramatic phenomena like loss of leaflets insertion, single leaflet attachment, but people also are looking for residual MR related to mitral anatomy distortion. I mean, when you grasp a lot of tissue in both anterior and posterior leaflets, sometimes you can open some clefts, or you can have a distortion of the mitral clip anatomy, so that you can create some other residual jets which are not so close to the mitral clip site of implant. And I think that maybe with this new aggressive mitral clip, which are larger and wider maybe this aspect should be taken into account when you try to perform an edge-to-edge repair with such technique. I don't know exactly what the future will tell us. Essentially, in the co-op trial, you have seen that with a good selection of patients, and especially in a very well-trained center, if you perform well the mitral clip implant, the rate of a single leaflet detachment is so low. They did not report the single leaflet loss of leaflet insertion. So maybe this percentage is a little bit low, and maybe the rate of failure is a little bit underestimated. But with new technology, I think that single leaflet detachment is a quite rare phenomenon.
Okay, thank you. Nice overview. So probably now is a good time we can take some questions. Julia, do you have a question?
Yes, I have a question to Antonio, also to Claudio, and to try to address the possible mechanism of failure, because I believe that maybe we can have a selection problem. Principle, the evaluation of the posterior leaflet length. And also we can have strategy problem during the procedure. For example, in a wide gap or wide prolapse, we use only one clip and not two clip to stabilize the gap. And after we can have a problem to the progression of the disease. And maybe with the new generation of clips, we lose the selection problem, the strategy problem, because we can learn more, but maybe the progression of the disease will remain. So what do you think, Antonio, about it?
But I discussed with one of the of the reviewer about this aspect, especially with the aspect of the co-op trial. So they have a very low 0.8%, which is stable across the years. They say that maybe thanks to the optical medical therapy that you achieve and you try to reach in all the patients, maybe you can stabilize, the negative remodeling of the left ventricle. But I agree with you that sometimes you find some mitral clip failure at follow-up related to progressive stretching of the mitral, especially in the progressive dilation of the mitral annulus, which leads to some tears very close to the mitral clip. And maybe this is one of the mechanisms that we found. You've seen that in some cases you find some loss of leaflet insertion also late at the follow-up, and maybe this is a mechanism. The problem, I agree with you, is always the patient selection. Maybe now with the new TMVR, with the possibility to implant enzyme and some other buds which will come hopefully in the next future, maybe we have not to treat these complex patients with a very short posterior leaflet or with some calcified spots on the leaflets, which makes the valve prone to failure. I think that in intermediate and high complex anatomies, we have to choose the right tool to fix mitral regurgitation, because it's not longer acceptable that you have a failure of mitral clip, because this is a real problem. If you have a failure of the annuloplasty, you have always the possibility to perform a second step procedure with a single leaflet device. But if you fail with a single leaflet device, I think that it's quite difficult to perform a second procedure. You have to cut the leaflet, you have to perform elasta, you have to implant a TMVR. But these procedures are very complex, and especially in our registry, no one reported this kind of approach. Most of the patients are then referred later on to surgery. And when you do surgery in such patients, you take the risk of a high mortality. And especially, even if these patients have no great mortality in the peri-procedural period, I think that the morbidity that you have in these patients is high. So people have very difficult recovery after surgery. So the point and the key point is the index procedure. When we do mitral clip, especially good patients like the one of co-opt, we have to make sure that the procedure will end with an optimal results, and these results should be maintained at the follow-up. Otherwise, we have troubles, because with medical therapy, we do not achieve enough. The mortality is still high. With surgery, we have some problems of mortality and even of morbidity. Sometimes you can do a redo mitral clip, but this is not 100% an insurance of success. We can mitigate symptoms, we can maybe mitigate the residual grade of residual MR, but we do not achieve an optimal result.
Okay, so let's take some more questions. So Kailash is asking, so some more, let's say, practical or procedural questions. What's the best way to make sure you've got proper leaflet insertion intraprocedurally?
The echocardiographyst, I think. So the problem is that you need good visualization, Arif. I think it's a very good question. So you need the good visualization of all the procedure. And with the new tools and with new echo machine, in most of the cases, you have 100% assurance that you have a good leaflet insertion. But you know, the problem is that you have good visualization in some cases, but sometimes you clip close to, you know, clefts or to spot calcifications, and when you release the clip, the result is bad. Sometimes what happens, and what I have experienced, is that you fix the regurgitation with the clip, you are happy while the clip is attached to the delivery system, and when you release the clip, then the problems comes out, and because you have a distortion, because you have opened, teared one of the leaflet, because the clip create a distortion of the mitral clip, the mitral anatomy. So it's the problem of the mitral clip procedure is that sometimes it's not predictable. That's the main fear that I think almost all the operators have.
And a follow-up to that question actually is, again, procedurally or practically, at the time of deployment, is there anything that you do or that you're mindful of, either to release the tension in the system or any specific maneuvers to avoid a sudden jump or a tear?
If what people and what we usually do is to release tension on the system. If you have some doubts, and if you are working with a good anesthesiologist and you see that, for example, blood pressure is very low during anesthesia, what you can do is to change the hemodynamic condition. So you try to increase the pressure, giving some inotropes, so simulating, you know, normal life and normal condition of blood pressure. And you can change the PEEP for the ventilation to see what is the behavior of the mitral clip. I think these are essentially the things that you can do. And another important thing that I want also to underline is to measure also the pressure, have a continuous pressure tracing of the left atrium, so that you can immediately understand what is the behavior of the mitral regurgitation. So also if you are missing something with the collar, you can prove what is the impact of your clipping before the release and after the release of the mitral clip. I think this is an important tool and a key aspect. I think that you have to be very meticulous, trying to grasp the more tissue that you have. And if you have suboptimal anatomies, especially if the posterior leaflet is not so long represented, I think that maybe we have to think about some other things. The problem is that commercially there are not so many devices available, and so operators are forced to perform mitral clip also in suboptimal patients.
Okay.
Antonio, I have two questions. The first question: what was the mortality for early versus late detachment? And second, if there was any relationship between the number of procedures performed over the year and the incidence or occurrence of detachment?
Okay, so the second question, we have not seen a dramatic decrease or increase of mitral clip failure across the years. And this is a little bit strange because I was imagining when I designed the paper and I thought about the manuscript, I thought that there was a trend towards the years. So it's a little bit strange. I think that maybe in the last years, even if more procedures are performed, the new mitral clip systems are better, and maybe they mitigate the number of failure that we could encounter. And the other aspect of mortality, exactly, I don't remember the number. I don't know if Claudio can help me, but essentially I don't remember the number. And maybe we have not performed an analysis between early and late mortality. Claudio, do you remember the
No,
numbers?
Antonio, we didn't do that analysis. I'm sorry.
Oh, okay. Yeah. Maybe we can look at that.
Considering the 30% mortality,
yeah.
I believe that medical therapy or surgery should not be utilized. You have really to do all the efforts to do a redo clip.
Yeah, I talked also with the guys from Abbott, and I think that in the next year they have this problem. They really understand the problem of mitral clip failure, and I think they are creating a device to even cut the mitral, which are badly attached to the mitral anatomy, and essentially to favor a TMVR in case of failed mitral clip. Because the problem of redo mitral clip, I think that is not 100% feasible. In some cases, you cannot do that, and you end up with the strange, solutions like attaching a plug between two mitral clips, and sometimes you can also create some stenosis, because when you have to add some other clips, finally, maybe the residual regurgitation is mitigated, but the risk of residual stenosis is even high. I think that the surgery should be just considered in case of massive residual mitral regurgitation, especially in functional patients with the poor ejection fraction, because I think that in this population showed in the other paper published in early intervention, the mortality is very high, and I think it's not acceptable for these patients.
In our experience, I remember in San Raffaele, if you put together the detachment and the failures and the surgery, the surgical mortality was 100%.
Yeah. I think this is a dramatic aspect. And if you look at the real world data, like the global expanded registry, finally, the mitral clip is a good therapy, is a good option. All the people, perform it routinely or nowadays. But finally, in real world data, at 1 year, around 8-9% of patients still have moderate to severe MR. So I think it's on a high percentage, and that's the rationale of improving, the technological solution to find a good TMVR to be performed in some suboptimal patients. But that the technological developments that we are trying to do, it's a little bit slow, and there are a lot of technical, I would say, aspects that have to be overcome.
And especially in the acute failure, this patient develop hypotension, low forward cardiac output. We never considered utilizing impeller in this patient. We utilize balloon pump, but maybe we should consider also some more aggressive support device.
Yeah, I think that I remember some cases in some dramatic cases, both in Cotignola, but especially in San Raffaele, in which we had failures, and patients after the procedure have a very dramatic, post-operative course, because sometimes what you do is even worse the mitral regurgitation. And if you worse the mitral regurgitation, the degree of mitral regurgitation in functional patients, sometimes you have some disasters, because they do not tolerate very well this increase in residual MR. And
the not a good solution.
Yeah, the balloon pump can be a bridge to something, but sometimes you even don't know what to do, because sometimes the only thing to do is doing surgery. But also with surgery, some of these patients have an acute afterload mismatch, and they have an high mortality. So that's the main point. And in these patients, as Mitral FR has told us, maybe, the impact of MR mortality and heart failure hospitalization is not so high. So maybe these patients should be, left to medical therapy alone. We still exactly don't know. For sure, we know, according to the co-op finding, that if we select a good candidate, we can, achieve a good results and a good improvement in terms of mortality and heart failure hospitalization. But in other patients, we don't know. Maybe the mitral regurgitation is just a sign of advanced heart failure, and everything we try to do to correct this aspect is irrelevant for the patient's prognosis.
Okay, so we're almost at time. However, Antonio, if you have maybe 2-3 more minutes, and Claudio, if you don't mind, we'll just answer some of the questions that people have been asking. Yeah. So great, thank you so much. So Marco and Alessandro both have similar questions. Basically, when you have a different mode of failure, either single leaflet detachment or lack of leaflet insertion, would you, let's say, not so much from a research or academic point of view, but practically in the clinical practice, would you have a different strategy to manage different types of tear failure?
So when you have a single leaflet detachment, so the mitral clip is truly detached from the leaflet, and so what you try to do, I think, in these cases, a reduced strategy is acceptable. I think you can achieve a good result. You have space, you have enough possibility to achieve even a good result. It depends on the mechanism of a single leaflet detachment, because sometimes you can have a tear, a damage on the leaflet, but if the leaflet which is detached has good quality, I think that if you try to do a redo, maybe you can achieve a good result. Sometimes if you have a leaflet injury, in case of loss of leaflet insertion, the problem is a little bit more tricky, because in most of the cases, the regurgitation comes just close to the previous mitral clip that you implanted, because there's a tear, there's a problem around the clip. And in these cases, it's quite difficult to fix the residual regurgitation. So I think that the approach is a little bit different. In some cases of loss of leaflet insertion, in most of the cases of loss of leaflet insertion, there's some papers about this technique of cutting the mitral clip, which is attached to the bad leaflets, I would say, and to perform the TMBR. But as I mentioned before, these techniques are quite extreme. I think that there are not a lot of centers around the world performing that.
Okay, and Jonathan, I believe you have a question if you'd like to ask.
Yeah,
maybe
so
Arif,
first of all,
maybe another mention. We have done one case of annuloplasty after mitral clip failure. Mm-hmm. It's possible, it's feasible. We implanted a cardioband. After all, the result was not so bad, but it depends on the mechanism of residual regurgitation. If you have a stretching of the mitral clip related to the progressive annular dilation, which occurs maybe at the later follow-up, it could be a good solution. But if your failure is very early in the peri-procedural period, I think that the annuloplasty cannot add so much. If you add annuloplasty, maybe sometimes you can close some clefts on both the anterior and posterior side. You can, approximate the distance between the anterior and posterior leaflets, but sometimes you cannot fully achieve, an abolishment of the residual MR. Sorry, Jonathan.
No problem. First of all, I just put the PubMed link for this very nice case report that you did together with Azim of this cardioband following TIA in the chat. So if you want to just look it up, the link is over there. one question to you, Antonio. In the literature, you often read two things with regard to implanting another device. Some say a second device gives you more tissue bridge, so more stabilization of a maybe LLI first device. And others say it rather gives you the risk of dislodging a first device that is close to a potential second device. So what is your take on that, especially regarding that you now have with G4 the possibility to like regrasp? Would you say one now would rather regrasp than do a second clip? What is your take on these two clips, sometimes called body clip techniques?
Yeah, it depends, Jonathan. It's a very good question, and it's a very good point. So it depends, as I mentioned before, it depends on the mechanism of failure and in the location of the residual jet. If you have a jet which is close to the first mitral clip that has failed, in some cases, people put a second clip very close. They tried to, reduce the residual gap, which is between the anterior and posterior leaflet. But if you have a tear, what happens is that you will have such residual MR between the two clips. And at this point, some people have done, putting a pledget, a plug between these two clips. I think this is a very artistic solution, but some people have said that is effective in reducing the residual MR. I personally have not done it before, but it can be a solution. The problem, I think, is that when you have a distortion of all the mitral clip anatomy with this new G4 with the very power grasping, I think then the problem comes out because sometimes you have multiple residual jets which comes from different points of the mitral, and so with the clip you can just target one lesion. Okay, but sometimes what happens is that if you target one lesion, the others remain immutate, and what you have to do is to perform, a sort of grasping around all the mitral valve. And the problem is that it's also related to the residual mitral stenosis that you can generate.
Okay, great. So I must say I could probably sit here and listen all day, but unfortunately, I think we do have to call it a close. Some of us have to get to work. So sorry we overran, but really the discussion was fantastic. And I have to say, Antonio, thank you. This is one of the best journal clubs we've had. We've really enjoyed it. Real expert insight. Claudio unfortunately had to leave again, back to work. So, but big thank you to Claudio for presenting this paper and for all of you for your discussions and comments. Prof. Colombo, hello, and everybody from Humanitas, thank you for joining us. It's a great pleasure for us.
Bye-bye.
Thank you.